So Mr. Chawla asked me, can you do a summary of who is winning in ARDS, who is losing in ARDS? I said, should I tell in a way Man United 0, Liverpool 1, in this way, somebody is winning? He said, that's fine. So what I'm going to do in next 20 minutes, I will be telling you several stories and who is winning in ARDS and who is ultimately losing. So if you have a look here, I live in Leeds and I didn't realize I was living near about 20 miles from me. One of the great men was living. Anybody has read any songs written by Wordsworth? Like a solitary reaper, many poems he has written. Never mind, he's a great man. He was born in that house, and he has written 1,000 poems. And he is just living there. He was about 20 miles from me. We have been talking several things about oxygenation, ECMO, ventilation, this way, that way. Do you know who discovered oxygen? He was from my city, where I am living. And the story goes, this was his laboratory, and this was his apparatus through which he separated oxygen. That was in 1774. Can you imagine what we had been doing before 1774? We didn't know what is oxygen. And we are talking about ECMO, oxygenation, ventilation, so many things. And this chap, and did you know how did he die? We nowadays, people die like in intensive care unit, connected to tubes, pipes, and all those things. And this chap who discovered oxygen, he went to bed and he told his son, I'm going to sleep as well as you. And he said, death is only a long sleep in the grave. And next morning he was dead. Can you imagine? And I was going on a morning walk with my wife, and we found out. And my wife said, do you know which house is that? And he is a Hollywood actor, and he was born here. And it was just two, three houses down to me. And he acted as a captain of the Star Trek, and he was knighted last year. And I'm very lucky to live near somebody. He's living. He's in Hollywood at the moment. This is my intensive care unit. And do you know what? The person who is sitting here, she is very powerful. Even not the consultants. So what she will do, she will switch off the lights from 4 o'clock in the afternoon to 6 o'clock in the evening. Do you know why? We just don't have any justification. Why do you do that? And he will not let any clinician to go into the patient unless there is an emergency. He thinks we are always disturbing the patient, intervention this way, that way, poking the lines, needles, and all those things. She said, at least give 2 hours rest in a day, which may be beneficial for the patient. And we had been talking so many questions arising from the previous talks. And if you think of, we have been talking throughout the day about ARDS, and just think of what's happening, thinking of what's happening to the severity. It is a line, the severity of ARDS is increasing. And we are talking about so many types of ventilation, so many modes and everything. And you will coming to a point when it becomes severe, then you will not be able to ventilate with conventional ventilation. Then you will be leading to needing the help with other agents. And this was the lady who died with H1N1. I got the permission to take the photographs. Why I am showing that this is in living, and have a look here, what heterogeneous distribution of this, how the ARDS is heterogeneously distributed. And this heterogeneous distribution, so what is basically ventilating in the portion B, which is the baby lung. And what I'm going to do in next 10-15 minutes time, I'm going to say who is winning, who is losing. And lastly, we are talking about the pulmonary vasodilators. And have a look. We have treated ARDS with Viagra. Can you imagine that? And we'll see the results. And this was the first cardiopulmonary bypass machine, ECMO machine. This was the first and came in 1954. And we did the randomized control trial in the 80s, no evidence. 90s, no evidence. And 2000, no evidence. And all of a sudden what happened last year, people started using lots of patients with ECMO. And this was the first patient in 71, and now we are using becoming like more common. And what I'm going to say in this sentence, if anybody in the audience can help me to complete the sentence, what I'm going to say, ECMO appeared to be life-saving in the year last year, in 2009 and 10. And I'm leaving the sentence, if anybody can help me, I'll come back to the sentence in a minute. And it came an editorial, oh, ECMO has come off the edge. It's just like more used just in time. And if you're not very clear about the ECMO, it's a simple technology. We think it is very complicated. And what happens, the blood is coming from the venous side, going through the oxygenator and going back to the arterial. This was the veno-arterial. And all the studies have been done with the veno-arterial. What happened? You are putting the blood back to the arterial side, and that makes more complication. And blood is pushed into the arterial circulation through a roller pump. That causes more damage, and you need heparinization. And what happened over the last 20 years? And we have gone to veno-venous. You collect the blood from the venous side, you change the pump to a centrifugal pump and push the blood back to the venous side. And this has just like your hemofiltration, or you call it like respiratory dialysis or something. It's just like a hemofiltration, getting very simple with the technology. You can see the venous blood is coming on one side and arterial is passing to the oxygenator, very simple, getting small. There is a centrifugal pump there. Technology has advanced. And what happens when the blood is collected from the venous side, going to the oxygenator, and when you see on the other side, after oxygenation is getting very red, you feel very happy, at least oxygenated blood is going into the patient. And this people, last few speakers, they spoke about this seizure trial. This was the trial. They recruited 180 patients into the trial, and what they did, if you have a patient, you ring me, and I'll randomize. If randomized to ECMO, then we'll transport the patient to my center, like their center. And if you're not like randomized to conventional ventilation, you will stay in your hospital, and you will be receiving the standard level of care. And this was done by a surgeon, not by intensivist. And this was done by a cardiac surgeon in a single center. And what happened? Can you imagine? In this side of the story, 90 patients were randomized to ECMO, and 2 patients died in the meanwhile. And when they transferred about all the 90 patients, 20 people that didn't require ECMO. So ultimately, 68 patients require ECMO. And in this trial, when you ask what is the 28 days mortality, they don't disclose. So what they have disclosed, at 6 months, without disability, that means you are not confined to bed, you can eat and drink, go to the toilet and all those things, and at 6 months, and this is the significance level. So that is the positive results everybody is talking about, and looking to their curve, at about 6 months down the line, ECMO is showing better results. And what happened when H1N1 hit everywhere, and in England, we had to do lots of ECMO. Ultimately, we got saturated. One day, this pregnant lady got very serious from Scotland, and we had to transport this lady to Sweden because we are running out of ECMO beds. So this was the first case. And after that, what happened? This was the only ECMO center which did the trial. And after that, we have like 5-6 centers coming in the UK. Even the Manchester, even Leeds, and 6-7 centers coming in the UK to do the ECMO. So it's not based on the randomized trials because there was a demand to do the ECMO. And then what happened all over the world, people started publishing their experience. What is my experience? What is Australian, New Zealand experience? And the Australian, New Zealand group, what they did like 68 patients, and they ventilated so many patients. Out of that, 68 patients required ECMO. And what was that trial? What is their mortality? And this is the 28 days mortality. It was not very promising. And they said, hang on, they're not getting really positive results. And they concluded the last line, in a selected group of H1N1 patients, it can be used. So that was their experience. And this is their result. if you look to the mortality rate here, in ICU 23%, 9% there, and similarly in the hospital. And Canadian experience, they didn't do that much ECMO. I was very fortunate to listen from the pediatric speaker. They do lots of pediatric ECMO. But in adult, H1N1, they did only 6 patients and 1 person died from each group. What about French people? What is their experience? And French people, they said, they did only 9% with conventional ventilation and randomized 9 to the ECMO, and then 1% died in each group, and they concluded an effective salvage therapy, please consider only. What is Italian? Italian are very good in ventilation, this way, that way, and they had like 12 numbers, and 3 had bleeding problems, and 1 died, and it was very encouraging. And I think in India they have done many cases. There was in news, in Hindu, it was in back sometime. This was the first ECMO patient they did. Apparently this was first, came in newspaper. And what about in Hong Kong? Hong Kong also, they ventilated 120% of H1N1. They had required about 7% being ECMO, and 1% died. And what is my thoughts after reading all this literature? I think technology has improved. Probably the use of ECMO will be again is going to be more popular. And because there was a demand, and partly the positive result of the seizure trial. And now it is appears sensible to go for ECMO earlier rather than waiting as a last resort. And throughout the world, what happened, about 256 patients received ECMO suffering from H1 and N1 ARDS, and we lost about 87 patients. So that's not very good. We were not 100% survival. And now I'll complete my sentence. ECMO appeared to be life-saving last year, and completing my sentence, in many situations, but unfortunately not all. And you have seen this man in the conference here. He postulated many years ago, you can break down the ventilation, gas exchange into oxygen and carbon dioxide removal. And this was my hand trembling in 2005. And this was the first patient I was connecting to the extracorporeal like partial lung support called Nova Lung. And you can see, the video is not playing, so you can't really see my hands, how they're trembling. And what happens, it is all previous speaker have spoken, blood comes from the femoral artery, goes to femoral vein, it depends the flow, depends on the mean arterial pressure, so there is no pumps in this one, so blood flow is very low, because it depends on the mean arterial pressure. This is the first, this is one of our patients on ECMO, Nova Lung, was suffering from ARDS. And if I think about Nova Lung, I have done about 37 Nova Lung patients, and however, if you think of, not a single randomized control trial has evaluated this device. And company says they have supplied more than 2,500 Nova Lungs to various countries, and patients have been used. And this is all literature available in this much. Is all dominated by the case series. There is not single randomized control trial. And you are not going to believe all this. So you are not going to Nova Lung after all this literature. You are not going to use the Nova Lung. So what happened on oscillators? These are the 2 types of oscillators available, and I use this one, like this is Nova Lung Vision Alpha. This is called Vision Alpha, and this is the Sensor Medic. 2 types of oscillator available in the world. So what's happening with oscillation? And there was a meta-analysis published last year, and what he was saying, if you look at the meta-analysis here, this side is favoring the high-frequency oscillation in ARDS, and this side is favoring the conventional ventilation. If you see, it is slightly swinging towards oscillation. But however, if you look at the incidence of barotrauma and problem with endotracheal tube obstruction, and it looks like it's going both ways. So it's nothing like clear-cut benefit of oscillation. So the oscillation in ARDS, people have published their trial. It was the randomized control trials are very quickly finished because many of ARDS patients due to H1N1. And if you analyze all these trials here, and what they did, like 30 days mortality, there was no difference. There's hardly any difference. And they said, okay, there was not like no difference in complications, but it is not causing that much harm. So probably safe and good for oxygenation, may improve outcome. We don't know. There are two ongoing randomized control trials going on at the moment. One is just finished. This is a multi-center trial done from Canada, and this is the trial is done in UK. We have recruited about 543 patients. I am the my center is the top recruiter of this study. So it's once these trials have been finished, that will probably give an idea what's the role of oscillation. The many things are better done in different positions. If you are going to win a war against Afghanistan, you have to do like various techniques like prone positioning. So what happens in prone position? It looks very comfortable. I like to sleep in prone position. A part of my night I can spend in prone position. But what happens? The nurses, they don't like it. They hate it. Because some sort of complication happens, so you put the patient into prone, or something is dislodged, something is come out. This is really, you have to put him back and go back again. So it's not really it's comfortable for the nursing staff. You can say, yes, do it. And look to what happened. Few years ago, Gattinoni said prone position is not going to be useful in terms of mortality. Now, they took all the trials and did the meta-analysis. They are saying it certainly improves oxygenation, no doubt. But it is prone position is reducing the mortality in patients who are severely hypoxemic with PAF ratio less than 100, very low PAF ratio. If somebody is severely hypoxemic, severe ARDS, then we'll consider prone. Because of the complications, associated risk, and we are not recommending prone ventilation at the moment. If you look to the result, this side is favoring prone, this side is favoring supine, and you can see all these randomized trials, the results are here, and one of them going that way, one of this going this way, all like sitting on the fence. But if somebody is severely hypoxemic, I would probably recommend, yes, we'll take the opportunity to prone him. What happens in ARDS? Can you give some extraneous gases and some pink cylinder, pink gases, and we call it nitric oxide. So when 10 years ago there was a positive result, we can use nitric oxide, one of the enthusiasts in my hospital spent about 10 million pounds and did the pipeline for nitric oxide. Can you imagine? He got a prize. Because this is the pipeline, oxygen, this suction and all those. This was the pipeline for nitric oxide. So I wouldn't certainly jump with a positive result like activated protein C. I don't want to jump immediately. Do something just like 10 million pound and went to the drain. And what happened after a few years? British oxygen company came and they just completely sealed that is dangerous to use and out of use. All the money completely went to drain. And what's the role of inhaled nitric oxide in ARDS? What happened last year? And have a look here. Cochrane, they did a good review. They take all the randomized control trials and how many patients, like 14 randomized control trials, 1300 patients, and mortality, there is no difference. And they said improves oxygenation, but however, is transient. No difference in length of stay, ventilator 3 days, and they are saying, hang on, we can't recommend to use any more nitric oxide. It may be harmful, so we are lost here. What about steroid? We had a debate on steroid, methylprednisolone, when to give to prevent the fibrosis in ARDS, and what's happening? Methylprednisolone is lost. It increases the mortality in ARDS. So that's why they wanted to see whether it has any benefit in community-acquired pneumonia. There is a couple of randomized trials, and you see what they did. They say in severe community-acquired pneumonias, steroid confers no additional advantage. So it's lost. So steroid is lost. What about the paralyzing? We don't like paralyzing anyone. But what happened last year, there was a study, randomized control trial, and they published, and they found that if you paralyze somebody very quickly with ARDS, paralyze and ventilate, then probably you are like improving the mortality, like your mortality is low. If you have a look to the result, here the mortality is on this side if you are paralyzing its cisatracurium, and is slightly higher if you are not paralyzing them. So this was the story with paralysis. The non-invasive ventilation came through the door, came through a corner door in the intensive care. Now is becoming common. I presume in next few years' time, you can buy non-invasive ventilation in supermarket. Maybe patient will go there, ask without the advice of the doctor, can I buy this CPAP or BiPAP? It is so common nowadays. And you can see some of the patients with ARDS, they can manage without intubation, without ventilation. These are the less severe degree of ARDS. Probably this patient would have gone through intubation, tracheostomy, weaning, and all those things. With all these patients we have seen, it helps less severe degree of probably ARDS. And you can see here, it's so common, like many articles, the number of articles on non-invasive ventilation is increasing every year. And what's the exact role? It was a study from the Chandigarh. They said non-invasive ventilation should be used cautiously in less severe cases and without minimal organ function in a monitored area, because there is a risk. If you have a look to the incidence of tracheal intubation in patients receiving non-invasive ventilation is about 50-50. So you have to see who can manage with non-invasive ventilation and maybe less severe case of ARDS. What about Viagra? So they thought it is a pulmonary vasodilator. It is a vasodilator. And they did the study and editorial, and they found that it does not improve the oxygenation in ARDS. It does not. So probably we lost here. In conclusion, ARDS is a spectrum of disease, like acute lung injury, less severe cases, more severe. It's difficult to know how severe you are. If you see a patient with ARDS, it's difficult to know how severe, where the patient is standing, whether the patient is here, patient is here, patient is here. And depending on where the patient is, probably will be non-invasive ventilation. We may win in some cases. We may go for conventional ventilation. We may win there. We may prone some cases. We may win there. And oscillation, we may win there. ECMO is getting more popular and more, it will be increasingly used, or for odd cases become completely fibrotic lung, we have sent them for lung transplant. It looks like all these modalities of treatment, they are going to stay. Amongst them, the oscillation and ECMO is getting more and more popular. And on the other hand, what's happening, your nitric oxide, corticosteroid, and all these things, they are struggling. Probably they will disappear from the armamentarium of our clinicians. I think it is exactly time. Thank you very much for your attention.